Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Dear colleagues and friends, welcome to episode 5 of Nasal Polyp Gossip. Today the Polyp Gossip edition is all about personalized treatment for our patients suffering from nasal polyp syndrome, or also called CRSwNP. So I'm very happy to have here with me Philippe Gevaert from Belgium, Martin Wagenmann from Germany, as well as Wytske Fokkens from the Netherlands, talking about how we try to personalize care for those seeking medical advice for a condition that we nowadays call nasal polyp syndrome or severe uncontrolled CRSwNP. So maybe Wytske, you first. How do you consider the option of personalized treatment for those patients seeking medical advice for nasal polyp syndrome?
Thank you, Peter. It's extremely important, and I think more and more used by all healthcare professionals to involve the patient as much as possible, to discuss with the patient what is the things they really suffer from. I really like the SNOT 22, for example. The patient feels that in my department before he actually sees me, and in seconds I have the information about 22 important items of chronic rhinosinusitis with nasal polyps or nasal polyp syndrome. So, and then we can discuss whether there's a sleep issue, or the lower airways are a problem, or work is a problem. And of course, the more obvious things that we always discuss, like smell, nasal obstruction, and rhinorrhea. And then we make a plan together and say, okay, what is the things you are most bothered with? What are the things we want to attack first? Which combination of symptoms do I think usually occur together and I expect to solve at once? What can be very difficult? For example, postnasal drip can be very difficult to treat. How is the interaction between the upper and the lower airways? What do I expect of a patient? What does the patient have to do to get the best results? If patients are smoking, for example, or have occupational exposure or allergic exposure, what can they do to help their situation? And in that way, we're a team. We're a team together, very often also with the nurse, to get the best result.
So thank you, Wytske. This is already a very comprehensive answer to a simple question. And actually, I was mainly triggered by the fact that you try to understand what bothers the patient most and you tailor the treatment to those aspects of disease. I address now a question to Martin Wagenmann. To what extent also do you take into account nasal polyp size, biomarkers in the blood, and other aspects of the disease that are not felt by a patient as such, but that also play a role in our decision-making?
Well, in this context, yes, they are very important, because some of these markers can tell us about the severity and the activity of the disease and the type of inflammation that is dominant in the individual patient. As we all know, I mean, the biologic treatments that we have are aimed against type 2 inflammation. And the more proof we get that type 2 inflammation is what we see in the individual patient, the better. So we draw blood, we look at polyp sizes, we do allergy testing, we look for comorbid diseases like asthma and aspirin sensitivity. I think that is very important. And the patient, it's relatively easy for the patient to understand that. We should and we can explain this to the patient, and that way we can have the patient, well, we can form a team together with the patient once he or she understands what all this is about.
This is a wonderful team play indeed, and you mentioned objective parameters of disease. But I'm always puzzled, and I address a question to Philippe Gevaert. Some patients may have small polyps and significant symptoms, and some others may have larger polyps and hardly be bothered by the large polyp. So sometimes we are puzzled by the discrepancy between the severity of the symptoms on the one hand and the way patients suffer from their condition. So how do you handle those? Do you only treat the symptoms, or do you try to look also to the full spectrum of symptoms on the one hand, and then also the clinical biomarkers, as we tend to call them, on the other hand?
I think here it's important to understand that treating a nasal polyp is not a one-size-fits-all. It doesn't work like that. And I think what Wytske already pointed out is we have to listen what the most bothersome symptoms of our patients are. And that can indeed be different within patients, and also it's not always dependent of the polyp size. A polyp can be very large, but it cannot be very active, for example. I call them sleeping polyps. They are just there. They are a remainder of an old war, but they are not active anymore. Or you can have these small polyps that are always with secretion and crusts around, active, juicy polyps. Those patients quite often have a lot of symptoms. So the size doesn't determine everything. But my first objective is to listen to the patient, what is the main symptoms that are bothersome, and then talk to my patient, what are the chances, the options to tailor the best treatment in function of their disease, their comorbidities, and their major symptoms. And that's in a nutshell what I would do.
Now, I heard the three of you telling or sharing the fact that you would listen to the patient. Is that actually something you've never done before, Wytske?
Of course, we always listen to patients, but there is more to discuss. There are more options, there are more choices, there are more things we understand and know how important they are. So the more knowledge we have, the more there is to share with patients, and the more there is to discuss how important something is. For example, an occupation of a patient that is unfavorable for the chronic rhinosinusitis can be an extensive discussion because, well, some patients easily say, okay, I'll take another job. But most patients say, well, that's my job. Sorry, doctor, but that's a very, very difficult decision to take. So, and then, of course, the patient asks us, how big is the impact? Will it change? Will my disease be better if I change my occupation, for example? Well, that's not very easy questions to answer. So I think the more we know, the more we understand of the disease, the more we have to discuss with our patients. So it's becoming more and more.
So it's becoming more complicated as well, being a doctor dealing with patients with CRSwNP or nasal polyp syndrome. We have more options, we need to invest more time. Is that also reflected in the time of your outpatient clinic, Philippe? Do you now spend 5 to 10 minutes more on every single patient, explaining the treatment options, taking into account the environment and all the external triggers that may have an impact on sinus surgery versus biologics versus a combination of both? Or is that not really true?
You can't do everything in one or the first consultation. It doesn't work like that. It's a kind of a longer term plan. In the first time, you have to explain them that they have polyps, what the consequences of that. Later, and then afterwards, they didn't hear anything of the consultation anymore. So if I also told you, like, we listen to patients, well, actually you have to guide them through their own symptoms. Because sometimes patients come and they have like 50 pages of small things they lived through in their day. If you start listening to that, it takes you 5 hours. So you have to guide them through what is important. And it comes in stages, to my opinion. So the first encounter is different than the second, the third, and afterwards. And in a way, you can listen, but you also have to be the guide. Guide them through their own symptoms and helping to understand what is relevant and what is maybe not relevant. They all have this, for example, nasal hyperresponsiveness on cold, on perfumes next to their polyps, and they might have listed every kind of trigger that triggers them. And then you have to explain them, well, you are responsive to all kinds of triggers, so you don't have to per se write them down for me. And so you are the guide, and that's also your role. It's not just listening, it's guiding them through their symptoms.
Martin?
Peter, I think your provocative start with, didn't we ask before or didn't we speak enough to our patients before, is also reflected into what you say and what Wytske also mentioned. You mentioned the SNOT-22. The SNOT-22 is a questionnaire, and it's always the same questionnaire for each individual patient. And that is extremely helpful, and that actually saves a lot of time. Yeah. So many questions we don't need to ask and write down. We have this written thing there, and it also says within the SNOT-22 which are the most relevant symptoms for the individual patient. At the same time, for example, we improved how we judge the size of polyps. Now, these days, we all use NPS, and my patients ask me, these days, they learn as well, how is my NPS today? And I tell them, no, I won't tell you until you didn't tell me how good you feel or how bad you feel, because they want to see this sort of improvement as well. But what I mean by that is we improve, we have better tools, we become better, and those allow us to save time for specific aspects, and we can use this time to educate the patient, for example. As you said, each time somebody has a new question, and the more serious we take our patients and the more we understand each other as partners, the better it becomes, I believe.
You mentioned improvement and better understanding, and many patients with nasal polyp syndrome, they suffer from anosmia, so smell loss. Do you think now smell loss is taken more seriously by the medical community or not? Thanks to COVID and thanks to new options, but maybe your opinion first and then Wytske.
Yeah, definitely. I mean, COVID certainly was a very important factor in that aspect that, everybody was talking about smell loss and loss of the sense of taste as well, which is always mixed up a little bit, but patients know about that. Finally, one of the reasons also is that we now have a very good treatment for that, because we know that treating these patients with nasal polyps with biologics very often, not always, but very often vastly improves their sense of smell. But again, in this aspect as well, if it's relevant to them and for some of the patients, it doesn't go back to normal levels, so they can do smell training, for example, so they as well can do something for improving their symptoms.
Indeed, smell loss has been neglected for a long time. We perform more smell testing. How is the situation in the Netherlands, Wytske? Do all ENT doctors perform smell tests in their patients coming to see their physicians for smell loss or not so? So can you comment on that?
More and more, we do that already for many years, but more and more doctors in the Netherlands use smell test on a regular basis. And I think another thing that we see more and more, which I think is extremely important, is that we now involve nurses in the treatment of our patients. I think that's really new for ENT. Pulmonologists have asthma nurses already for, well, as long as I'm a doctor. But for us, that for a long time was not regular. And I really think that that is an enormous improvement in the care of our patients, because nurses can talk to patients and spend a lot of time, do smell testing, for example, and allergy testing, but also they have a lot of knowledge on nasal polyp syndrome and can answer lots of questions, and in that way be a really important part of the management team.
Would you agree, Philippe?
I fully agree on the nurses, but I think for smell testing, we still have a long way to go. It's very obvious, for example, when you have a hearing loss that you are tested with that. But for smell loss, there is not a good nomenclature. We heard also, for example, that all over Europe, It's quite often not well reimbursed. Even in my hospital, when I want now to do the smell test in every patient just to show that it's better after the biologicals, it's said like, well, but we need a nurse for that. Is that a well-spent money for a nurse? So they question this, and so we are not yet there. We are not yet there in Belgium, we are not yet there in Europe, that smell test is a standard way of evaluating whether you have smell loss or not. And so I think we still have a long way to go until smell testing will be a standard that we have to offer to our patients, because a long time we have neglected smell loss because we had nothing or no options to treat. And so I think we do it better, but we are not yet there.
Okay, we mentioned smell loss as one of the cardinal symptoms of nasal polyp syndrome and how to deal with that. What about nasal obstruction? If you see a patient with severe nasal polyp syndrome primarily complaining about nasal obstruction, how do you deal with those and what do you explain them in the context of diagnosis and option? Maybe Wytske first and then I hand over to Martin.
Well, you know, nasal obstruction is of course caused as long as there is a lot of polyps blocking the nose. And I explained to the patient that, well, I only see revision surgery patients. I never see primary patients. So the discussion of what's the first choice is there, I don't have to do that. So for me, it's revision surgery versus biologics, for example. And then I discuss with the patient that surgery is a fast way to solve that problem, but that I think that the chance that the polyps will regrow is larger than when we treat with a biologic. But for a biologic, it may well take a few weeks to a few months before the nasal obstruction is totally solved. So that is the balance I discussed with the patient. And in an ideal world, you might say, well, do a short polypectomy just in the outpatient clinic to give instant relief and then start a biologic. But that's usually difficult to organize for us.
Would you agree, Martin, on that? Because this is a kind of provocative statement as well.
It is. I mean, the relation between biologics and surgery is not an easy one. And in patients where we removed polyps and then by definition don't see polyps anymore, we have a problem indicating the biologic treatment. Because this is one of the aspects that needs to be fulfilled. There need to be polyps on both sides. But in general terms, yes, I mean, we did see, I mean, in the beginning, early on, when biologics were new, we expected that, you know, patients with really large polyps obstructing the whole nose, probably it wouldn't work with biologics. Now we know better. Even in those patients with complete obstructions, biologics might do a pretty good job. So it's really an option that we have, and the timing is relevant. And the question if there are other symptoms. And you said before, I think, you know, sometimes the patients don't even realize what symptoms they have, especially with the sense of smell. If we don't rely on smell testing, very often patients that lost their smell months and years ago, they forgot about that. And only after treatment, when the smell comes back, they tell you, oh, I can smell again, what happened? And that's, you know, that's something that needs to be considered as well. And we need to understand the full spectrum of the symptoms.
If I may bring another topic that is very relevant for our community listening to Polyp Gossip, it's all about oral steroids and how we consider oral steroids in the context of quick symptom relief, a quick fix of the problem in a cheap way, without too much admin burden for the physicians and an easy win for patients. Philippe, how you consider oral steroids as a way of discussing with your patient a treatment option?
Well, a long time ago, when I was much younger than now, I did the double-blind placebo-controlled trial with 20 days of systemic steroids. And what we learned there is that in all the patients, they had some beneficial effect during the treatment period. What we also learned during that trial is that all polyps returned back to before in very short time as well. So we didn't cure or did anything beneficial on a long time in any patients in that study. So what that tells me is that you can only use it for emergency situations or when you have no other options at then. But for a long-term treatment, it's not a good treatment. And for a long time, like remission and cure, thinking about a plan for your patient, a tailored plan, it's not what we need.
Okay, you mentioned it's not what we need. I can live with that, but do you also consider adverse events as a reason why not to repeatedly prescribe or consider oral steroids? And I hand over to Martin.
Yes, absolutely. I mean, I think this is something that we largely underestimated, how often patients with, especially those severe patients with polyp recurrence after surgery, how often they actually receive systemic steroids. And as we all know, and as our patients should understand as well, the more often you take these drugs, the more likely it is, or it becomes, that you will suffer from side effects, and some of them are irreversible. Diabetes, weight gain, osteoporosis and fractures, just to name some. And that is a real problem. Although these drugs are cheap, we use them too often. And one other aspect is, not only we use them, we do prescribe them sometimes, but what we have to understand is that very often once the patients realize how well they can feel for a couple of days or weeks using these oral steroids, they very often find ways to convince another physician to prescribe these oral steroids. They have them in their drawer, and whenever they have the feeling, I feel bad, some of these patients by themselves use oral steroids. And that's why we underestimate that, and why we really have to consider the potential of side effects of these drugs.
No. Would be good, Wytske, if you could share with the audience also your opinion on oral versus nasal corticosteroids, because if we put corticosteroids in such a negative daylight, it may feed corticophobia, which is to some extent justified when we talk about oral treatment, but actually that's not the case when we talk about local or nasal treatment. So maybe, Wytske, you could discuss that topic, which is of relevance for our audience.
Well, I would like to emphasize what Philippe and Martin said first, that there were recent studies in the UK that really changed my view on oral corticosteroids. You know, I was taught when I was young, well, 2 courses a year is acceptable. The pulmonologist did that, and we all did that, and we felt it was okay. Now, there are data from the UK showing that even 1 course, not 1 course per year, 1 course at all in your life already has significant higher chance of severe side effects like osteoporosis. And we don't see that because that's in 20 years. And I think we are really responsible for stopping that, not giving systemic steroids anymore unless we really do not have any other option. We cannot defend in say in 20 years that we gave them, although we had another treatment, but it was expensive. I think that is something that we have to, that if we have to defend ourselves that we did that's a wrong thing. Nasal corticosteroids, of course, is totally different. If patients listen to this, nasal corticosteroids, the steroid is, it's like when you go to a hotel and you have a key with a huge hanger on the key to prevent you from putting the key in your pocket and taking it home. That's the way a nasal steroid works. So the nasal steroid cannot be taken into the tissue. It remains in the nose. And so there are no side effects. And it's different for the skin, and it's a little bit different for the lung. But in the nose and sinuses, you can absolutely safely take enormous amount of nasal corticosteroids without any side effects over a long period of time. And we can give it to little kids with allergic rhinitis, for example, and you can take it for the rest of your life without any problems. So I think it's very important to explain to patients the difference between nasal corticosteroids that can be taken for a long time and oral corticosteroids that we should really try to avoid as much as we can.
Wonderful. Well, we dealt with steroids, we dealt with surgery, we dealt with biologics, but what about, and this is of relevance for our audience as well, what about the lifestyle, the environment, the microbiome? Do we have any clue to what extent those factors play a role and to what extent they also determine the choice of yours if you have a patient with severe disease in front of you? I know this is a challenging question, therefore I address it to Philippe.
Thank you, Peter. I think, for example, there are some occupations like hairdressers or painters that when they come to me and they have polyps, I'm not happy with their profession or with their hobbies, and I don't have a solution for them. That's the problem. I can only tell that they are worse in response to my classical treatment and surgery when they have that.
Could I just interrupt you here?
Yeah.
In those kind of patient populations, I would recommend wearing a mask during the work time and also excessive nasal douching before and more even after the work environment exposure, because that may help clear the nasal cavity from irritants, low molecular weight agents that cause inflammation.
My hairdressers don't want to wear masks. They say, how can I do that? My patients will think I have a flu or have COVID. So that's a hard discussion, but I fully agree with you. It's not that I don't agree, but patients will not always do what we suggest them to do.
Wytske, do your patients listen to you? No.
No,
Okay.
no, we know. Philippe is absolutely right. You know, there's fantastic research in Canada about the amount of prescriptions for nasal corticosteroids that are actually collected from the pharmacy. And that is awfully low. And I think we all realize that. How often do you say to a patient, do you need another prescription? And they say, no, I still have enough. And you know that means they didn't use it. And I understand, you know, I really understand. It's challenging to rinse your nose every day, to use nasal corticosteroids, to avoid all sorts of stimuli. So it is not that we tell patients and just think, well, do it. I think we all understand how difficult it is on a daily basis and we can help patients to make it routine.
So if I understand you well,
I really like, for example, medication only twice a day or once a day, so that you can say, okay, whenever you brush your teeth, you also use your nasal spray. Things like that are easy to make into a routine, but it's not easy.
So Wytske, you just mentioned the patient do not listen to you, whereas you would advocate for listening more to patients, which is actually nice in contrast and maybe opposite of what have been done in the past. Would that be the same in Germany?
Well, yes, of course. But I would like to address another issue. Sometimes we also need to tell our patients in terms of treatments what they should not do. You mentioned the microbiome, for example. We all know that this is an absolutely fascinating topic. We do know that the microbiome and its composition certainly does have an effect on the inflammation in the nose. But what we also do know is that there is no treatment currently available that will change the microbiome of the nose to a composition that is more healthy. But many patients buy stuff that, you know, promises to do that. So we need to tell patients, yes, this is important, but there's currently no treatment available for that, for example. Or just another example, some patients, and we need to ask them about that, still use decongestant nose drops. And that's bad for their disease and for their nose. And we also need to tell that and explain why this is bad.
And I think on the same topic, I think some patients use broad-spectrum antibiotics even when they have no acute disease or exacerbation, just because they think, or their GP thinks, that this might work. And then you even kill your microbiome or the good part of your microbiome. So I think that's also one of the things you really need to avoid, is using broad-spectrum antibiotic, because you might think it works maybe, but it doesn't, we know that.
I think we could go on for hours when we talk about everything we do not know about nasal polyp syndrome and how to achieve a remission or cure in 100% of our patients. But for now, I think we need to kind of close this episode, because we can't wait to move on in the field and also discuss during the next episode the multidisciplinarity of care and how collaboration with our colleagues from pulmonology, allergology, immunology might also improve outcomes of nasal polyp care. And therefore, I would like to first thank our colleagues, Philippe, Gevaert, Martin Wagenmann, and Wytske Fokkens, for their kind collaboration and thoughtful insights in nasal polyp syndrome care, and also invite you to join us for the next episode of Nasal Polyp Gossip, which will be around the multidisciplinarity of nasal polyp syndrome care. Thank you very much. Polyp Gossip.
This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.